Hello everyone and welcome to this audio podcast. This audio podcast, a series as part of a Juxta NewsBeat series or edition. This audio podcast as part of a Bostix Biosphere, and this audio podcast as part of a Storm Bostix production. In this audio podcast, a look at vesicoureteral reflux, vesicoureteral reflux or VUR. So, vesicoureteral reflux, or VUR, um, it generally is a retrograde flow of whether it's urine from the bladder into and through the ureters, and toward the renal tubules, as part of the renal tubules, and secondary to where there's a dysfunctional vesicoureteral junction. It is generally an anatomical issue, and or sort of a functional dysfunctional disorder. Uh, Serious consequences that can occur as a basis of VUR are renal scarring, and also where there can also be renal damage or renal failure. VUR is generally is historically, or at least in the literature, has been documented as quite common in pediatrics, in pediatrics and young people, and VUR can be isolated, identified, and referred to as primary reflux, or associated with sort of bladder or urological abnormalities such as posterior urethral valves, or urethrocelli, which are referred to as secondary, or where there's secondary reflux. And the vesicoureteral junction allows urine flow from the ureter into the bladder, and prevents sort of backflow. The pathogenesis around VUR are thus are twofold, and thus there's primary and there's secondary. Primary is where there's is one of the more sort of common forms of reflux, and occurs during where there's incompetent or um, um, incompetent or inadequate closure of the uretrovesical junction, and it is usually detected shortly after birth. Secondary VUR, it is a result of sort of abnormal high pressure in and around the bladder, that results in failure of the closure of the vesicoureteral junction during bladder or urological contraction, and it is usually associated with where there's an anatomical basis. So, for example, posterior urethral valves, or functional bladder, or where there's a functional bladder obstruction. Here, I thought I provide a sort of a basis around VUR sort of grading, and there's five sort of grades, five sort of gradings, forms of grading, and basically, grade one, for example, is where the reflux generally does not reach sort of the sort of renal, around the renal pelvis or renal pelvis area. However, there are varying sort of degrees of urethral dilatation, And then grades 2, 3, 2 to 5 generally are where there's a basis around sort of mild to mild to moderate to a sort of severe sort of deformities around the ureters and where the renal parenchyma is also affected. The etiology around VUR is where due to sort of congenital anomalies, congenital sort of abnormalities are not or where there's congenital anomalous development of the uretero-vesical junction. Um, um, the etiology around the renal parenchyma again is affected and excuse me, incomplete development of the intramural uretral tunnel causes failure of normal valve mechanism at the uretero vesical junction, thus permitting reflux around the bladder into the ureter and renal pelvis. The reflux can occur when the tunnel is ordinary or is ordinarily where the tunnel is ordinarily sufficient if the bladder pressure increases due to bladder outlet obstruction or dysfunctional voiding. Around dysfunctional voiding, there can be sort of infrequent voiding, and the infrequent voiding can also cause issues such as constipation as well. Unfortunately, in those who are diagnosed with forms of VUR. The risk factors are several, so there can be age, and there can be an age risk factor, there can be reflux grading, there can be lower urinary tract dysfunction, anatomical abnormalities, and sort of renal pathophysiology status as well. Excuse me. And around the epidemiology. So within the general population, and sort of in the literature, VOR has been highlighted as being sort of presented in 1 to 2% of all pediatrics or children. There are racial and gender differences as well. The incidence of VUR in black children, for example, is 1 in 3 to Caucasian or white children. Boys are more likely to have VUR than girls or than females, and familiar sort of relationship where there's 80% of prevalence between identical twins and 35% in non-identical or fraternal twins, and siblings of children of children with VUR in sort of a documented works had been identified as having 27.3% risk of contracting or having VUR. The incidence of VUR is higher amongst children or pediatrics, for example, who where UTI, urinary tract infection, is evident as well. So as part of the diagnoses, there has been a guideline a guideline and documented sort of bases from the the American Academy of Pediatrics, where they have recommended ultrasonography and avoiding cystoscopy, urethrophy, or VCUG, and or a radionuclide cystography, and the standard criterion for diagnosis of VUR is through the detection of VCUG. Renal and bladder ultrasound, or RBUS, has been evidenced as sort of an ideal screening modality. It's non-invasive, and uses no sort of radiation as part of the sort of as part of the imaging. And however, it has been identified that RBS unfortunately sort of has a sort of poor sensitivity and negative predictive basis for sort of absolute identification or determining VUR. So part of sort of the diagnoses, the diagnostic work also includes evaluating the presence of urinary tract infection or UTI, renal status, in identifying around the sort of the renal parenchymal presence of VUR, and again, where there's in context of urinary tract infection, it's as part of the diagnostic workup. It's important to identify the lower sort of lower urinary tract function as well. A basic diagnostic workup can comprise where, for example, there's a medical history, a physical examination where applicable, and including blood pressure, urinalysis, and again, as sort of assessing for proteinuria, and urine culture, a measurement of serum creatinine. The first two the first two ultrasonography scans or imaging is important within for example, at least for at least the first up to the first 2 or 3 months of life, and are important in determining the presence or absence of renal parenchymal pathology abnormalities. VUR is rare in infants or pediatrics with two or normal successive postnatal ultrasonography investigations. And some of the in line with conservative or sort of non-surgical therapy. The objective around conservative therapy is prevention of primarily around febrile urinary tract infection. The conservative approach also includes sort of waiting, monitoring intermittent antibiotic prophylaxis or continuous antibiotic prophylaxis, and bladder rehabilitation in recipients, especially where there's lower urinary tract dysfunction or LUTD. And the follow-up with with imaging investigations is part of the conservative management to monitor sort of spontaneous resolution around renal pathophysiology. And in works and in literature, there's sort of evidence to inform that biannual ultrasonography of urinary tract and annual or less frequent cystography and DMA contrast scanning, DMSA contrast scanning can be helpful. The most frequently used agents for continuous antibiotic prophylaxis are sort of single low doses of antibiotics, for example, amoxicillin and historically trimethoprim. However, trimethoprim in sort of more recent, in sort of in sort of literature now, trimethoprim has can cause unfortunately can cause sort of contraindications around renal insufficiency and can cause nephrotoxic side effects. However, historically and in literature, low doses of amoxicillin and trimethoprim or sulfamethoxazole and or with nitrofurantoin can be used in sort of as part of conservative therapy. In around around treatments, open surgical treatment is also a part of a VOR. So all the techniques focus on generally lengthening the intramural part of the ureter by the submucosal embedding of the ureter, and all the techniques are generally safe with a low rate of complication, and generally there's an excellent success of prognosis in and around 92 to 98% in recipients who undergo sort of open surgical treatment. And the most popular, at least has been documented as the Cohen-Cross trigonal reimplantation. Related to the VCUG, so VCUG for most specialties in around the sort of the pediatrics setting, VCUG had remained as a sort of a gold standard as an imaging investigation for diagnosis of VUR. The investigation is or can be somewhat invasive. There is potential radiation exposure, and the risk of potential iatrogenic UTI with urethra and bladder catheterization. Is or can be part of screening. VCUG is recommended in sort of recipients with where there's ultrasonographic findings of bilateral high-grade hydronephrosis, so where there can be narrowing or obstruction to the urinary tract, and where duplex kidneys with hydronephrosis and urethrocelly and urethral dilatation, alongside where abnormal sort of bladder sort of abnormal bladder pathophysiology is also evident. Early screening is more effective than late screening in preventing further renal damage by early diagnosis and treatment. VCUG is recommended at age at sort of neonate up to 2 years of age, and after the first proven febrile urinary tract infection has been sort of identified. Related to sort of VUR management, the main goal in and around this is where there should be a preservation of renal function by minimizing the risk of VUR alongside pyelonephritis and or acute pyelonephritis. An investigation for the presence of lower urinary tract dysfunction should be performed in pediatrics, or the young people who have sort of toilet will have sort of toilet training. And endoscopic treatment is an option for all pediatrics with low grades of reflux. In high risk recipients who may already have sort of renal dysfunction, a sort of a progressive multidisciplinary approach is required, since with VUR there is with VUR there is a urological or bladder involvement as well. All patients diagnosed within the first year of life should be treated with sort of prophylaxis antibiotics where appropriate. Immediate antibiotic treatment should be initiated for febrile infections and where there's evidence around that. Surgical endoscopic correlation is the preferred treatment in recipients with with frequent infections, and surgical correction where appropriate is considered in recipients with high-grade reflux, especially where there's high-grade reflux, grade 4 and 5. So summary around this audio podcast on VUR. is recipients with VUR should be informed that there can be a high probability of VUR in siblings and in offspring. If screening is performed, siblings should be screened by renal ultrasonography. VCUG in literature has been one of the main sort of recommendations, and if there is evidence of renal scarring on ultrasonography, or a history of, and especially of where there's a history of urinary tract infection or UTI. In older and those who are recipients who are toilet trained, for example, there is no added value in screening for VUR.